Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Lana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back, Turd Nerds. We are excited to have you join us in Rebecca's office. Today is a super important topic for, I think, all of us, but especially for me, because we're going to be talking about Candida today. But we're not going to be talking about Candida in the way we've talked about in the past. We're going to be talking about a Candida allergy situation. So let me build a picture. I have these patients. I think anybody who's been listening to the Turd Nerds and treating fungal overgrowth in the intestine has this experience where you go out and you run a lab, like maybe a Candida immune complex, and the number is high, or a Candida IgA, IgG, or IgM, and the number is high, and you treat with antimicrobials and pharmaceuticals and herbs and diet, and you do all of the things, and then you rerun the lab, and the patient isn't feeling better, and the labs aren't changing, or even worse, they're going up.
Right.
And so then you just keep going and going. Fungal treatments feel like they can go forever. And I had gotten lost in what that means. And then I was on a conversation, either a text thread or actually talking to Ami, and Ami brought up this concept of, oh, it's not that it's the bug, it's that the immune system has formed an allergy to Candida. Like it's an allergic reaction.
And ironically, even though I've been trying to I do general medicine at this point, in the past 2 weeks, I think I got 3 texts from people asking me hey, what do you think about this? I'm like, all of a sudden,
Can't escape it.
Yeah, I was like, okay, whatever, we'll do an episode.
I feel like this topic is a little higher level clinically, because it's sort of you have to kind of understand Candida. You probably have to have some experience treating it, but also a lot of patients stall out in their treatment. So they do the herbs, whether they're self-treating or working with, a naturopathic doctor or functional medicine doctor, and they're just not getting traction with it. So even though we are going to kind of get into the weeds, I think a little bit today is super relevant to a lot of people.
Right.
Probably all of us included, I would say. Candida is a problem everywhere.
Well, the tricky part about it is, so there's a little booklet by Dr. Sydney Baker that's like a pearl, full of pearls. It's from the early 80s. I think I posted it on my website a long time ago. And it's this weird thing, because in regular medicine, we know you have to be very careful about the terminology you use, right? Because you shouldn't really say someone has a Candida infection unless they're sick in the hospital. But it's an organism that lives internally, and we also have external mold everywhere. So it's this sort of unusual organism where there's sort of external hits of fungi, and then there's these internal microbes that we have that can get out of balance. It's not an infection. Most people.
It's an opportunist, I think. It lives everywhere. It should be living everywhere.
It's a commensal that can become problematic under certain circumstances. But I also just want to throw out there that we should be careful, because it gives kind of some of the integrative practitioners a bad name if you start telling people you have an infection when they don't, and patients get confused too. So, and the tricky part about the allergy is that if you have an allergic predisposition, you can become allergic to the organism. And basically that makes it really hard for your body to get it back as get it back into check as a commensal.
Would that happen if it's just low level living in your body, or is it mainly these people that are dealing with an overgrowth, or however you want to label it?
It's a good question.
I think happy in the body.
Yeah, so the only research I found supporting this allergic connection was in women with recurrent vulvovaginal candidiasis, and they did a few trials where they treated them with Candida immunotherapy.
Yep.
And it significantly helped, 2 small trials. It significantly helped with prevention of relapse.
Wow.
Okay, wait. Can I just break that down for a second? So they're using slit therapy? They were using slit therapy?
They did injection immunotherapy, but the company that we've talked about at conferences and such that teaches doctors like us who want to do slit therapy how to do it will include Candida in the antigen mix for your patients if you want to treat them for that along with anything else they're allergic to. And I don't have evidence for this, but I would think people who become allergic to this have a general predisposition for allergy. It's not like they're not allergic to anything else and then they have this one allergy. I mean,
like an atopic picture perhaps, or positive testing on allergy testing.
Usually, I would think it would be unusual to become isolated.
Unless it was very severe.
Yeah, allergy to one. I mean, I would think you'd have some cross-reactivity to other molds or to pollens or dust mites or what, just because, your body's kind of overreactive to things.
I imagine most of our data is on vulvovaginal.
Yeah.
Is that true?
It is. Up until the last 5-10 years, there's been those few publications that we talked about.
With Dr. Rao.
Right, with GI Candida. And then there's some other GI doctors in California who definitely believe in it. But there's not like a bunch of published data on it, for other outside of the GU tract.
In general.
Like tinea picture.
You mean related to allergy?
Yeah.
I don't see that as much.
So I have a number of folks that were working on their gut, for Candida. And maybe they have a vaginal or genital history, but definitely axillary, under breast tissue, in folds.
More susceptible to, yeah.
Usually people who also have diabetes or higher blood glucose levels kind of feeding the Candida.
Yeah.
I would imagine that would predispose you maybe more to an allergy as well.
I don't think so. I don't have any data on it. I have not seen it for people with like onychomycosis or tinea corporis, that kind of thing. But for Candida, in various areas of the body, I would think that you'd be more predisposed. Although I've also seen that isolated in people who they sweat a lot, they're in construction, etc. They don't have an internal problem. It's just like external factors,
They work out a lot.
Yeah.
Okay. So here's my big question clinically, right?
Yes.
I'm not a researcher. I'm a clinician through and through.
Right. Neither am I.
What is the algorithm?
I'm a clinician.
But yeah, I mean, you're like half and half. I mean, you're like probably 2/3.
I spent like 7 years in research.
You did a bunch of research.
Yeah, I have some publications on my website. But,
Dr. Sand, you're like famous.
Yeah, but not in this field. Market translation.
Okay, for me as a clinician, for our listeners who are a lot of physicians, what's the algorithm? When do I go in and think this is something that I need to treat with antimicrobials, with biofilm, this is a bug problem, versus this is no longer a bug problem. I need to think outside the box. Is this an allergy problem?
And how do we know looking at tests or what triggers us to think?
Yeah, so I mean, if it's someone you've been treating ongoing, they're not making progress, you're pretty confident that it's yeast Candida issue, like you keep doing, recurrent vaginal swabs and they're actually positive, or their GI symptoms respond but then come back, specifically to antifungal therapy. Or some people, they don't respond to antifungals because it is an allergy and you're never going to get rid of it completely.
But their antibodies, serum antibodies, would still be elevated in that case?
It doesn't have to be, but I mean, you do check those. The IgG and the immune complex typically go along with an overgrowth in the GI tract.
Right.
But there's not a specific blood test for allergy. Typically, I would send people to our local friendly allergist who would do skin testing.
For Candida.
For Candida. There's another allergist, I believe, in Southwest Washington who also a lot of our doctors refer to, who also, I think, has posted on one of our sort of, message groups that we're all on, that he's found various people with different allergic skin issues respond to Candida antigen. And then there was a doctor who created the slit therapy through one of the companies we use, who was big on this as well. And he also found that it was helpful to include that with the mix of everything. So you can't always prove it unless you're an allergist and you can do skin testing for it. And everyone has you should have a delayed reaction to Candida, but if you have an immediate hypersensitivity, like we check with other allergens there's various ways to test. I'm not an allergist, but they have ways where they can be more or less.
So to definitively figure it out, you need to do skin prick testing through an allergist office that offers this.
But you might not need to definitively figure it out.
Right. If you, I highly encourage those of you who are interested to do the slit therapy. Is not
Should we define what that is real quick?
Yeah, the sublingual immunotherapy. If you have an allergist, I would just refer them to to the allergist that you like. But if you don't have access, sublingual immunotherapy is done by many medical doctors, naturopathic doctors who are not allergists, because you can't get people into an allergist in a lot of communities. So it's been used in Europe a lot. In the US, it's, there's prescription tablets for very isolated allergens, but you can also use companies that the pharmacy will formulate the mix for everything the person's allergic to. You can run an IgE panel for your region through LabCorp request. I would always add on the Candida, but you don't have to have that be positive to include it in the mix. They'll still include it if you have clinical suspicion.
So I want to break that down for a minute. I want to break that down. So what you just said is, if you have a suspicion of a patient possibly having some allergic override and maybe an intolerance to Candida, you will run, like in the Northwest, we have like Northwest Allergy Panel 13 or whatever. So you would run a panel like that.
Yeah.
Plus you would run the Candida IgA, IgG, IgM.
And IgE.
And IgE.
But you don't, the reason I run the IgE was almost never positive, but at least I want to check for that. I don't know if anyone's ever seen it positive, but the skin testing seems much more accurate because I didn't have positives. But again, the company that did the slit formulations, the pharmacy, was, because of the doctor who created their protocol, they know that this is a problem for people based on his research and initial treatment. So they will include it for you, and they have a standard way so that you can safely do that. And no one will have an adverse reaction that's serious if you do it in the way that they teach you.
And you're doing that. And this is all, the Allergy panel is a IgE panel.
Right. The allergen panel is an IgE panel. And so you would generally include all of the traditional allergens, pollens, dust mites, weeds, trees, respiratory allergens, although they can cause symptoms in all systems.
Yeah.
But this is different from a food allergy panel, which is different from a food sensitivity.
Which is, right.
We want to distinguish.
Yeah, so an IgE food allergy panel, anaphylaxis, IgG hypersensitivity panel, food intolerance,
food sensitivity.
And you can get some traction in treating serious food allergies by treating their environmental allergens because of the cross reactivity, which I learned from our friend.
How often do you see this with a mold allergy?
Well, so you first have to get them out of. You first have to figure out if they have environmental mold.
Right.
You figure that piece out. You treat them for the gut stuff. You treat the biofilm. There are some people that just will not respond despite doing all of that. Or if they have an immune system issue and you just think this is going to be an ongoing problem for them, it could be just a complementary therapy that you add on slit to while you're doing all the other things.
Yeah.
Because I have not seen it make people persistently worse. Like they might have a little bit of trouble and then we back up on the dose a little bit or the frequency of the dosing, but it's not typically a variable that's going to make the overall picture muddier. It's going to just improve their immune system function over time by keeping those allergic reactions down.
Can you explain, just for our listeners, how the slit therapy is working with your immune system to help with a Candida reaction?
Yeah, I mean, I think it's supposed to be the same as allergy shots, where it builds up your tolerance over time.
So slight exposure, you
to very small doses.
They tolerate it.
Yeah. Okay. And you get to a final dose that's generally been found to be helpful. And for the slit, typically they recommend at least 3 years or so of BID dosing, I think it was.
Yep.
For immunotherapy, like shots, they typically recommend 3 to 7 years. It just depends on
such a commitment.
But you space it out, over time.
So let me just remind our listeners and educate our listeners who might not know. The way the immune system works is we've got IgM, which is a pentameric molecule. It's got these 5 little hands, and these 5 little hands find 5 little things and say, is this me? Is this not me? This is me. Great. No reaction. Move on. This is not me. And then the immune system asks, is this something I need to form an allergy to? Yes, I'm going to mobilize my histamine. I'm going to go anaphylactic. Throat's going to grow up. I'm going to get all itchy. That's IgE, right? IgG is more like how we respond to a cold or a flu. You feel bad. The next day you feel worse. The next day you feel really, really bad. You feel really bad. You feel better, better, better. It's an arc of like somewhere between 5 and 21 days or 30 days. That's a much slower reaction.
Or it can be years for some.
Or it could be years, right? Yeah. It's a much slower reaction.
This last flu season, let me just say.
And then there's like...
I'm just kidding.
And then there is an oral, what they call oral tolerance or Treg response, which is, this is not me, but this is something that I need to live, right? So this is a food that I need to eat to give myself nutrition. This is a nutrient. and that pentameric response literally goes in that order. If you form an IgE reaction, you can get stuck there, or you can push it into an IgG reaction. You can never go backwards. Or you can push it to an oral tolerance reaction. You can never go backwards. So the whole theory of either slit or injections or shots, allergy shots, is to push you out of that stuck place of histamine, hypersensitive,
Risking anaphylaxis and dying.
into an oral tolerance T regulatory response, right? So that's what we're talking about with immunotherapy, either sublingual or IM or subQ.
It's just, you mean allergy shots or sublingual, or we didn't talk about sort of the alternative medicine ways, but there's also the LDI and LDA that we've talked about a bit, that also anyone can learn. That is yet another way to turn the switch on the more serious reaction to more of a tolerance reaction.
So it's basically like removing the danger of being exposed to something. It sort of like tones the immune system down a little bit, so it's not like threatening the organism if you're exposed. It calms it down a little bit to like, you may have some symptoms, but it's not going to cause this like avalanche of
that's the goal. Yeah, and I can't remember all the physiology of how it works, but I just know. Yeah.
Okay, so the important thing to recognize is the reason why we have this conversation more now than we did, say, 50 or 100 years ago is because our exposure to pathogens is non-existent.
And because my childhood was covered in Lysol. Like, none of us build immune systems.
And I think there's even studies on increased air pollution and such, increasing
so many
reactivity
on our immune system being able to generate in the first place.
A normal immune response.
Yeah.
And that's not...
childhood.
That's
antibiotics, C-section.
That's not talking about nanoparticles and
acids. Petroleum-based additives?
They're working on it.
Okay.
They're working on it. And I mean,
thing.
I hear that. And on the flip side, Europe doesn't have a lot of petroleum-based allergies.
Right, and they still have allergies.
Yeah. We do live in a toxic sludge of a world.
Yeah.
And, it really, the high
description.
So I can remember I was hanging out with one of my New York cousins, and she, like, come on, I'm a naturopath. I don't believe, I believe, but I was not obsessed with germs, And she was looking at me. She almost started crying because she thought I was abusing my child because I wasn't cleaning up and Lysoling everything. Like the
Lysol. Do people actually use that?
Oh my gosh, I can't even with Lysol. If I smell it now, because it was all over my childhood.
We luckily didn't have that.
And I got ear infections, asthma, everything.
Parents think they're doing a good
What's
thing.
What's in that stuff? I don't even know.
Bleach.
I can smell it just talking about it.
Okay, I don't even know what it is.
So
I know what it is. I don't think
But does this person have children?
Yes, she had 2 children.
I don't, my child mostly eats off the floor.
Which is and you have a dog, which is so good.
I mean, I'm like, I look at her and I'm like, at least she's eating something with protein, or a mineral in it.
My husband's like, when did protein become our religion?
I know. Your daughter's rebelling against your dietary
my daughter would only eat gluten and carbs if she had away.
Most toddlers at least are deficient in minerals, so dirt. Right?
Right.
That's totally logical.
Okay, let's pull it back to the data. Okay, so here's my question. As a clinician, right? So I run this panel. I'm working them up. It's not SIBO. Okay, what looks like SIBO but isn't SIBO? SIFO. Okay, I'm going to run the test. The test is positive. I'm going to treat with a low...
And you checked for protozoa given the severity of Cryptosporidium issue, which will cause resistant Candida.
Can you talk to us?
No, in what Dr. Crinion's one of his oldest papers, he was like, there's a list of things if someone's not responding, this is what you check for, a list of items. Toxins, heavy metal toxins. Excuse me?
Because of how it messes with your immune system.
Well, she knows more than me about how Giardia changes the microbiome, but I think any protozoa will make it more likely that there's more imbalance with other things, So.
Yeah.
I will say that, the parasites are real damn clear. They usually cause luminal damage. Not
you can tell from the symptoms.
But the protozoa,
the
microbiome.
Yeah. So if you are going to do a SIBO protocol and you can throw in some nitazoxanide as part of one of your guys' newer therapy protocols, that'll also cover protozoa.
Okay, but let me back up.
But then if they still don't respond.
Okay, but this is the fork in the road that I'm not sure when I'm supposed to make the turn to allergies. Okay. My fork in the road is I'm going to start a medication. I'm a naturopath. It's probably going to be low level, relatively safe. I might go to the next level up. At what point do I say, I drug this person to exhaustion? When
okay, do they have eczema? Do they have allergies? Do they have
So
Just in general, yes, and or just resistant symptoms, and or did they respond to the mold-free diet that we would teach about? Like, do they do better if they don't do yeast and fermented foods and moldy foods and things like that? And some people react to citric acid
And vinegar, right?
Vinegar, except for white vinegar. So if they're having adverse reactions to all those things, they had atopy, they're not responding to any of your protocols, then you might want to start thinking about allergy. If they have time, it doesn't hurt to go get some skin and intradermal testing done just to see, because if they're like pan-allergic to everything, then this might be part
It's
of
just
their
part of the
picture.
mix. How do you distinguish this from just histamine issues?
Yeah, that's a tricky one. I mean, histamine's going to be there if they have these other problems, but it's still not the root cause. So it's sort of like, even if they have histamine issues, it's just one more reason that you might want to check for allergic issues if it's not responding. Yeah.
Because, as we've talked about many times on this podcast, so many of our gut people have histamine issues.
Yeah.
Some of our gut microbes produce histamine, and people can't degrade
It's a
it.
problem.
I imagine this would be just
This would contribute to it as well.
Yeah.
Yeah, so I guess what I'm hearing, and I don't know if I'm done with questions, but what I'm taking away from this is you go through, you do the microbial things, and if they have this, or maybe if they walk in with this atopic presentation to start with, maybe I want to.
You might want to just include it in part of your. Although some people, the allergy part will just get better as you treat the other. So it's always like a tough call. If they've been sick for 20 years, it wouldn't hurt to get some testing just so you know if that's one avenue you can treat.
That's another thing. If it's been going on longer, does our suspicion go up that they have developed an allergy to it?
I mean, maybe not, because they've probably never seen a doctor who's treated the stuff that you guys are going to treat in
I
your
guess,
office.
when we're doing our initial intake, let's say, what could bump this up on our list? So, I always say, what have you tried? And if they've been on fluconazole or nystatin on and off, and it's maybe gotten a little bit better and then come right back, gotten a little bit better and come right back, and now they have gut issues or respiratory issues, or that would probably raise my suspicion.
I mean, people who become allergic to things just manifest also. I mean, they skin issues, dermatologic issues, gut issues, GU issues. It can contribute to all the things.
It's everywhere. It is literally
it's
everywhere
on our
in the whole
mucous
body.
membrane. So it's all hard to know exactly when.
I'm thinking about a patient right now, a really complicated patient who, before seeing me, he worked with a physician who had him on nystatin for 2.5, 3 years. And he was doing relatively good. He was plateaued, but in a not bad place.
Yeah.
And then we pulled him off the nystatin because it was just a really long time to be on it. His Candida immune complex is still through the roof. And then I switched to fluconazole. He did relatively well, but then he's still plateauing. And so then I sent him over to one of my people that I refer to who does Lyme testing. Mm-hmm. And it turned out he was Lyme positive.
Yeah, anything that'll suppress your immune system, right?
And it was very interesting because, so this clinician, he's a naturopath. He started him on 1 drop of the Burpito.
Oh.
One, no,
that's
no.
That's not for something for tick-borne?
Yes, it was 1 drop of some herb for tick-borne.
Okay.
And he started losing his hair. He had a crazy,
That's crazy.
Lyme stuff goes though.
But I am also
so rough.
I'm wondering if with the Lyme treatment, if he is not a terrible candidate for getting worked up.
Well, all of those infections, if you have them chronically, will switch your immune system right out of balance from the Th1, Th2. So if he does manifest those symptoms and they're open to allergy treatment, I see it as generally one of the things in regular medicine where we can actually significantly affect the immune system in a positive way.
Right,
long term, and even after
using slit therapy,
or immunotherapy.
Okay. So, question kind of,
or injection in immunotherapy.
If someone comes to you in an acute flare, they are bloated, they can't tolerate foods, their skin is reacting, is there a time that you would want to initiate slit therapy, or would you want to hold off in an acute flare, or doesn't it matter?
I mean, I would try to get them as stable as you can, because otherwise they're going to say they're reacting to this, whatever you're using. So to try to get them in some minimal balanced state before you start.
So maybe use your anti-candidal herbs or whatever you need.
Or anything else you're going to do, antihistamines or dietary stuff or, nervous system stuff.
With histamine therapy? If you put some cromolyn or something like that, you can do that?
I'm not an allergist, but I don't know of any contraindications to.
Do you see them flaring? when you initiate slip therapy?
I didn't have anyone flare. I mean, I did it for a few years, but I didn't have anyone flare. They would occasionally get very minimal oral symptoms of something. It wasn't even like the protocol that I was using. They had never seen an anaphylactic or serious reaction if you did it in the format that they recommended based on this allergist's work.
But that is one of the reasons why they haven't come into the office, because there's always
for the first treatment, for the first drops. For the shots, you always go in the office.
Yeah.
For the slit, you can do it at home after you.
It's such a game changer for people.
Yeah.
Do you give an EpiPen?
I always give an EpiPen.
Yeah.
I would always give an
Just
EpiPen.
everyone have
Yeah.
EpiPen.
Yeah, EpiPen.
Why not?
Yeah. I agree.
But try not to use it. Have it, but try not to use
I
it.
know. Makes sense.
So it seems like this, for our chronic atypic-like people, this needs to be in our field of thought. And there doesn't seem to be a large risk with initiating slip therapy.
There's various protocols. Again, I am very cautious, so I asked them a million times, and yes, they had literally no reported serious reactions if you follow their.
That's a really good
Yeah.
track record.
Yeah, but that's not the case for all forms of slit. So I still prefer to do it through an allergist. But if you don't have access to one, then, it's nice to have something.
I think, the first 3 episodes we launched was CIFO, right?
Right.
Like that was episode 1, 2, and 3. And I got really excited about treating fungus, right? So started ordering Candida immune complexes. I was checking everybody. And that was, 3 years ago? So I've had a lot of follow-up on it.
Yeah.
I am significantly less excited, and now I'm
Right,
filled with more dread.
I feel like it's one of those things that has so many branches that you have to consider. You've got the histamine, you've got the allergy, you've got other chronic disease,
I
other
also
dysbioses.
see the markers go seesawing up and down.
Right.
And so I'm not sure how helpful it is to follow those markers. I've never seen any data on it. I don't know if it's better to just check it once so you know if it might be a problem, or if following it is actually useful and figuring out if someone still has a problem. There's just very limited data on it. We need more
I have people that I
studies
have
on invasive testing.
I have people that I have absolutely brought down into normal ranges.
But then does it go back up again and they still feel fine?
So I generally still will check that at least once a year.
Okay.
90% of those people right now, and obviously the longer you do medicine, the more these things change, will maintain in that negative place. And so I have one patient I was thinking about in particular who had terrible, seborrheic derm.
Oh yeah.
And fungal tinea, right? And he had been using topical antifungal, topical ketoconazole, a topical steroid, and maybe an antibiotic.
Oh.
Because I think he had rosacea also.
Okay.
And so he had been using that for years and years and years. We went in, we treated the gut. He was an engineer type person, so he followed my directions to a T. He was able to completely eliminate it and stay down, and his skin is still there.
Oh, good.
And so
he doesn't have an allergy issue, or it resolved, and in some people, for whatever reason, it doesn't resolve when you treat the issue.
Or they're not as compliant, because it's really hard to do a low.
I don't know. My patients were compliant.
That's what.
You have him maintain a low carbohydrate
Not.
diet.
He's still eating what I'm gonna lovingly call a naturopathic diet, and sometimes he'll sometimes he'll overindulge in sugar, and then his skin will get a little worse.
Okay, so he will still get flares if he needs a lower carbohydrate diet to maintain his remission of the symptoms. Okay.
The hardest thing is sugar. Hardest thing with Candida
because sugar is more addictive than heroin,
cocaine,
and heroin, and more available.
Especially if you have Candida, it
I was trying to teach my
and they're trying to detox it out. It wants to be fed, and it sort of protests in your gut. If you stop eating it, you get lethargic, you feel worse.
Can I throw in a quick story?
Yes.
Okay, my 9-year-old niece always candy. Every Easter egg hunt spreads out the candy. I'm like, what are you doing? And then goes through, I was like, do you have a limit on how much you're allowed to eat a day? No, not on holidays. I was like, seriously, I'm sure there's some limit that you're
Judgment. Okay, go.
Then I said, have you heard of crack cocaine?
What did she say?
She said, I didn't know my brother-in-law was in the bathroom. He's like, I heard you telling her about experiments. So I was telling her about the experiments with I don't know if it was cocaine or heroin, where the mice would push the lever for sugar or the drug, and they would push it for sugar over the drug. So anyway, that was my lesson to my niece.
And me, I know. You know what I mean? It's not like I don't know.
Oh yeah, I love sugar, especially in the wintertime.
I wish I could. I wish I only loved in the wintertime. That would be great.
I've found though, because I ask a lot of people about sugar. I do a lot of like metabolic health and whatnot, and it's really just killing us all, as we know. But people who have a history of Candida, it is like this. You can't control it, and they're the people that like you have a cookie and you have to eat the whole.
But I feel like that's so many people.
It's not me, and I have a lot of people that's not them too.
Interestingly, not me either,
Right.
but it is my husband.
So
and when you make that cake thing.
Oh my God, which one?
Oh,
when you had to send it back to me, when you had to send my cheesecake.
She left the cake at my house, and my husband said it's like putting a pack of
wait.
together.
It was a paleo cheesecake. It was a paleo, no refined sugar.
We have no self-control. So, well, you know how they give you a second wedding cake to keep for? We ate it all in like 2 days.
You guys are like made to be together.
So we can't buy it. But I don't think I have an active dysbiosis. I think it's like emotional eating.
I think
that's a
stress.
Thing.
Yeah.
It complicates.
Okay. I know we're coming to the end, but and I'm going to open up a Pandora's box, so I'm sorry. Where does heavy metals fit into the algorithm of Candida?
Well, the theory in the old naturopathic integrated medicine world, I don't know of any research for this, so don't blame me. But if you have toxic metals, apparently Candida helps find them. And so you get an overgrowth of Candida secondary to the heavy metal toxicity. The integrative doctors have been like arguing about that for years, if it's a real theory or not. But any toxins will reduce your immune system function. So it's not, it seems logical that if you have a high toxicity burden that you're going to have more dysbiosis, which is why I've been telling you for years that you've got to include the testing, which Dr. Anderson has a really great webinar.
Oh, he does?
It's from several years ago, but it still seems quite accurate. On I don't know if he updated it or the slides were from like 2016, but it seems still quite pertinent that we should talk about at some point.
What I have heard recently is you want to treat Candida before heavy metals because mobilizing it as you would to chelate or whatnot will actually release more that's more absorbable into the body. So the Candida
goes both ways, which is why some people do binders when they're doing antimicrobial protocols.
Right.
Or psyllium or something, right? Some kind of fiber. But you kind of have to address both. I always think it's better to get your GI tract in as good shape as you can before doing any detox protocols.
Yep.
So that makes sense. So you got to add that to your list.
I just want to make one. I want to say something, and then I want to just dot what I'm saying for a future episode. I think I might be cheating on psyllium with acacia fiber. Dot.
I don't like any of those.
Okay, great. So future episode is coming.
We've got a controversial argument.
Future episode, it's coming. Okay, so can we just recap real quick?
Go ahead.
Let me start and then you finish.
Sure.
Okay, so there is this pool of patients with fungal atopic-like pictures where the problem that they're having is not so much the bug, it's an allergic reaction.
Or both.
Part of the problem that they're having is allergic reaction to Candida. If that is a pool of patients, we are going to want to possibly test them, like intradermal skin testing through an allergist or through a naturopath or functional medicine doctor that does that in your office. And if they come up with this intolerance, one of the things that we will consider is sublingual immunotherapy or slit therapy to address the immune lack of balance because the immune system is revving too high to Candida, which is already everywhere.
And probably the multiple other allergens that they're inhaling and ingesting that will make it hard for them to respond to any other
our episode on atopic IBS.
Mm-hmm. Okay, so that is a pool of our fungal patients that are going to continue to make us crazy, but maybe give us another tool. Yeah. What else did I miss?
I think for me, the lens is like when they come to me, what I'm looking for. And, for all of us, I think we have patients who've sort of been through the ringer on treatments and then find us through whatever means. So, doing a thorough history and what have you tried? What other systems are affected? Is it skin? Do you have a chronic recurrent history of this, exposure time? And then ask about allergies. Do your thorough review of systems. Do you look allergic to things? Because that would heighten it for me pretty quickly, I think. Chronicity and allergies.
As always, I am excessively grateful for my peers who have such different experience and help me be a better clinician.
And you guys who have unusual curiosity on unusual health topics.
It is nice. It is nice to have no other interest besides this. So thank you guys. Thanks, Church, for tuning in.
Thanks,
Bye, guys.
Bye.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.